You have been sitting on the toilet for 20 minutes, scrolling your phone, and right now, something very uncomfortable is happening inside your body that you have absolutely no idea about. Most people treat their digestive system like a black box. Food goes in, something comes out, and everything in between is a mystery they would rather not think about. But that mystery is exactly where hemorrhoids, fissures, fistulas, and some of the most painful conditions a human body can develop are quietly building up. And by the time you feel them, they have already been there for a long time. I have spent years studying colorectal health, and the single biggest reason people end up in serious trouble is not genetics, it is not bad luck, it is not even diet. It is neglect paired with total ignorance about what the lower digestive system actually does and what it needs to keep working properly. So today, I am going to walk you through the real biology of what is happening inside your body when hemorrhoids develop, how they progress, what your treatment options actually look like, and what every single person watching this needs to start doing differently before this becomes their problem. Because I promise you, this is not someone else's problem. This is a human problem, and roughly 75% of adults will deal with it at some point in their lives. The rectum and anal canal are not glamorous topics. Nobody wants to bring them up at dinner or even at the doctor's office, and that embarrassment has real consequences. People wait. They hope it will go away on its own. They buy creams at the pharmacy and hide them at the back of the cabinet. And the whole time, the underlying condition is getting worse. So let me just be direct with you for the next few minutes, because your health is worth a straightforward conversation. Inside your anal canal, there are clusters of tissue called the internal hemorrhoidal plexus. They have always been there. They are normal. They contain blood vessels, connective tissue, and smooth muscle. And under healthy conditions, they help seal the anal canal and give you fine control over bowel movements. The problems start when these vascular cushions become engorged, inflamed, or displaced. That happens for a handful of very predictable reasons, and once you know those reasons, you realize how much control you actually have over whether this ever becomes your problem. Straining is the number one culprit. When you sit on the toilet and push hard, you dramatically increase the pressure inside your abdomen and your rectum. The veins in the anal cushions get compressed, blood pools, walls stretch, and over time, the tissue loses its elasticity and starts to bulge. This is not a one-time event. It is cumulative. Every single straining session adds to the damage, and most people strain for years before they ever see a symptom. The second culprit is time. The longer you sit on the toilet, the longer your anal muscles are in a partially relaxed open position, and the longer gravity is pulling blood into those vascular cushions with nowhere to go. Research is actually quite consistent on this. Spending more than 5 minutes on the toilet is associated with significantly higher rates of hemorrhoidal disease. The toilet is not a reading room. It is not a phone zone. It is a functional stop in your day that should take a matter of minutes, and if it is not, that is your body telling you something is wrong with your digestion, not an invitation to scroll deeper into your feed. Low fiber intake is the third major driver. Fiber is what gives your stool its bulk and water retention. Without adequate fiber, stool becomes hard and compacted, and hard, compacted stool requires straining to pass. The average person in many Western countries gets roughly half the daily fiber their digestive system needs. The result is chronic mild constipation that most people do not even recognize as constipation because they have never experienced a genuinely easy bowel movement to compare it to. Now, here is where things get complicated because not all hemorrhoids are the same. Internal hemorrhoids develop above the dentate line, inside the anal canal, in a region where there are no pain receptors of the type that register sharp sensation. This means internal hemorrhoids can grow significantly before you feel anything at all. What you will notice first is typically bright red bleeding on the toilet paper or in the bowl. Not dark blood, not mixed with stool, just fresh, bright red blood after wiping. That is the classic early presentation. Many people see it once, convince themselves it was nothing, and move on. That is a mistake. Any rectal bleeding should be evaluated by a physician. Full stop. Because while hemorrhoids are overwhelmingly the most likely cause, they are not the only cause, and the conditions that can also cause rectal bleeding are not ones you want to miss. Internal hemorrhoids are graded on a scale from 1 to 4. Grade 1 means the tissue is engorged, but stays inside the canal. Grade 2 means it prolapses, or slips outside during straining, but goes back on its own. Grade 3 means it prolapses and needs to be pushed back manually. Grade 4 means it stays outside permanently and cannot be reduced. The higher the grade, the more limited your treatment options become, and the more significant the intervention required. External hemorrhoids are a different situation entirely. They develop below the dentate line, where pain receptors are abundant, and they hurt. They feel like a swollen, tender lump at the opening of the anus. When a blood clot forms inside an external hemorrhoid, which is called a thrombosed hemorrhoid, the pain can be severe and sudden. It comes on fast, peaks in the first 48 to 72 hours, and then gradually improves over a week or two as the clot is reabsorbed. If you see a doctor within the first 48 hours of a thrombosed external hemorrhoid, surgical incision to remove the clot is an option that provides almost immediate relief. After that window, conservative management is usually preferred because the clot resolves on its own faster than the surgical site would heal. Treatment for hemorrhoids follows a progression based on severity. For early-stage internal hemorrhoids, dietary and lifestyle modification is the first line of intervention. Increasing fiber intake to 25 to 35 grams per day, increasing fluid consumption to keep stool soft, eliminating toilet time beyond functional necessity, and avoiding straining. These changes sound simple, and they are, but they require actual commitment. Most people try them for 3 days, feel marginally better, and then go back to their old habits. That is not treatment. That is a temporary interruption. When lifestyle changes are not enough, office-based procedures come next. Rubber band ligation is the most commonly performed procedure for grade 2 and some grade 3 internal hemorrhoids. A small rubber band is placed at the base of the hemorrhoid tissue, above the dentate line, cutting off blood supply. Over the following days, the tissue dies and falls off, usually without the patient even noticing. It sounds alarming. It is actually well tolerated by the vast majority of people because the procedure is performed above the pain receptor zone. Mild discomfort, a feeling of pressure or urgency for a day or two, and then resolution. Multiple hemorrhoids can be treated in sessions, spaced a few weeks apart. Success rates are high, though recurrence is possible if the underlying habits do not change. Sclerotherapy is another office option, where a chemical solution is injected into hemorrhoid tissue to cause it to shrink. It is used more often in patients who cannot tolerate rubber band ligation or who are on blood thinners. Infrared coagulation uses heat to coagulate the blood vessels feeding the hemorrhoid. All of these are outpatient procedures done in a clinic setting with no general anesthesia required. For grade 3 and 4 internal hemorrhoids that have not responded to office procedures, or for patients with significant external hemorrhoid disease, surgical hemorrhoidectomy is the definitive treatment. This involves physically removing the hemorrhoid tissue. It is the most effective long-term option, but it comes with the most significant recovery. The anal region has a dense nerve supply. Womb healing in a moist environment is slow, and the area is under constant functional stress. Postoperative pain is real. It can be significant, and patients need to understand that beforehand. Most colorectal surgeons will tell you that hemorrhoid surgery has one of the worst pain-to-procedure complexity ratios in all of elective surgery. That is not a reason to avoid it when it is indicated. It is a reason to go into it prepared, with adequate pain management and realistic expectations. A newer surgical technique called the procedure for prolapse and hemorrhoids, or stapled hemorrhoidopexy, uses a circular stapling device to remove a ring of the tissue above the hemorrhoids, pulling prolapsed tissue back up into its normal position and cutting off blood supply to the hemorrhoids simultaneously. It tends to have less postoperative pain than traditional hemorrhoidectomy because the staple line is above the pain receptor zone, but long-term recurrence rates are somewhat higher, and it is not appropriate for external hemorrhoid disease. Your surgeon will discuss which approach makes the most sense based on your anatomy and the extent of your disease. Now I want to spend a few minutes on something that does not get nearly enough attention, and that is the conditions that either accompany hemorrhoids or are frequently confused with them. Anal fissures are small tears in the anal mucosa, or skin, most commonly at the posterior midline. They cause sharp, searing pain during and after bowel movements, often described as passing razor blades. The pain triggers a reflex spasm of the internal anal sphincter, which reduces blood flow to the area and impairs healing, which is why fissures become chronic. Treatment involves softening the stool, topical agents that relax the sphincter, calcium channel blockers, or botulinum toxin injections. Chronic fissures that fail conservative management may require lateral internal sphincterotomy, a procedure where a small portion of the internal sphincter muscle is divided to relieve spasm and allow healing. Anal fistulas are another condition entirely. A fistula is an abnormal tunnel that forms between the inside of the anal canal and the skin surrounding the anus. Most develop after an anal abscess, when the abscess drains, but the internal opening does not close. Fistulas cause persistent drainage, pain, and discomfort, and they do not resolve on their own. Surgery is required. The challenge is that the fistula tract runs in close proximity to the sphincter muscles, and the entire goal of fistula surgery is to eliminate the tract while preserving sphincter function so the patient does not develop fecal incontinence. Various techniques exist depending on how high the fistula tract runs relative to the sphincters. Some cases are straightforward. Others are extraordinarily complex and require staged procedures over months. Recovery after fistula surgery is prolonged, and your surgeon is not exaggerating when they tell you that the procedure is 30% of the treatment, and the remaining 70% is your body's healing. The common thread through all of these conditions is that they are largely preventable with the right habits and largely manageable when caught early. The people who end up in the worst situations are almost universally the ones who waited too long, who were too embarrassed to see a doctor, or who kept hoping the problem would resolve on its own. So here is what I want you to take away from everything I have told you today. Eat more fiber, genuinely. Not a sprinkle of chia seeds on your yogurt, but a consistent daily effort to reach the recommended intake through vegetables, legumes, whole grains, and fruit. Drink enough water. Do not spend unnecessary time on the toilet. Do not strain. If you see blood, see a doctor, and do not talk yourself out of it. And if you have been living with discomfort, pain, or symptoms that you have been silently tolerating because you are embarrassed to bring them up, please make an appointment. Colorectal surgeons and gastroenterologists see this every single day. There is nothing you could describe to them that would surprise or embarrass them. What actually troubles them is when patients come in after years of avoidance, when the situation has progressed far beyond what it needed to be. Your digestive health is not a minor detail. It affects your quality of life in ways that touch everything from your comfort and sleep to your ability to work and exercise. Take it seriously, take care of it proactively, and do not let embarrassment make your decisions for you. If this video helped you understand something about your body that you did not know before, share it with someone who needs to hear it. And if you have specific questions about any of the conditions I covered today, leave them in the comments, and I will get to as many as I can. I will see you in the next one.